All right, let's talk about psychotic disorders. If you've ever felt like telling these apart is like splitting hairs, you're definitely not alone. But here's the thing, getting this stuff right is an absolute goldmine for USMLE points. So today, we're going to build a simple, powerful framework for these diagnoses that will actually stick with you.
Here's our game plan. We'll start with the absolute basics of psychosis. Then we'll use schizophrenia as our main anchor. From there, we'll master the differential based on just 3 things: how long it lasts, if there's a mood component, and a few other key features.
So, first things first, we got to build a solid foundation by figuring out what psychosis actually means. It's a word that gets tossed around a lot, But for the USMLE, you have to be precise.
Okay, this is probably the most important point to get right from the start. Psychosis isn't a disease. It's a symptom. It's a fundamental break from reality. Think of it like a fever or chest pain. It's a massive red flag that something is wrong, but it doesn't tell you what is wrong. The cause could be anything from schizophrenia to delirium from an infection or even substance use.
So psychosis shows up as a cluster of symptoms, and for your boards, you really need to know these 3. First, you've got delusions. These are fixed, false beliefs that just won't budge, no matter the evidence. Then hallucinations, sensory experiences, like hearing voices when there's nothing actually there. And finally, disorganized thought, which you'll spot in the patient's speech. It becomes illogical, jumbled, basically revealing that the thinking process itself is breaking down.
And check this out. This sentence is a perfect classic example of a specific type of disorganized thought called clanging. You see how the words are linked by sound, not by meaning. Cow, how, bow. It's a rhyme. Spotting these kinds of speech patterns in a clinical vignette, that's a super high-yield skill.
Okay, so now let's see how these symptoms come together in our prototype psychotic disorder, schizophrenia. I promise you, if you can get a solid grip on this diagnosis, all the others become way, way easier to figure out.
All right, the single most important number you need to associate with schizophrenia is right here: more than 6 months. And listen, this isn't just 6 months of active psychosis. It's the total duration of the disturbance. For the USMLE, this timeline is a hard and fast rule, no exceptions.
So the symptoms of schizophrenia are broken down into 2 buckets. You've got your positive symptoms, which are things that are added on, like the hallucinations and delusions we just talked about. But honestly, it's the negative symptoms that are often more devastating. These take away normal functions. You get a flat affect, where there's no emotion, a total lack of motivation, which we call avolition, and the inability to feel any pleasure at all, which is anhedonia.
This slide right here, this is basically just a list of guaranteed test questions. You absolutely have to have these associations memorized. They love, love, love to test the link between heavy cannabis use in teens and later psychosis. For imaging, the classic finding you're looking for is in large lateral ventricles. And for the pathophysiology, it all comes back to the dopamine hypothesis, that excess dopamine is driving those positive symptoms.
Okay, so we've hammered home that 6-month rule for schizophrenia. Now we're going to see how that one single factor, time, is what we use to define 2 other very closely related disorders. This is probably the most straightforward part of the entire psych differential, so let's nail it down.
This timeline is your anchor. Seriously, memorize this. The only thing that separates these 3 disorders is how long they last. Less than a month, it's brief psychotic disorder. Lasts between 1 and 6 months, it's schizophreniform disorder. And once it crosses that 6-month mark, bam, it's schizophrenia. It's really that simple.
Okay, now we're getting to the part that trips up a ton of people. How do you untangle psychosis when there's also a major mood episode, like mania or depression, happening at the same time? The key, and I mean the entire key, is looking very carefully at the relationship between the psychosis and the mood symptoms.
This is a classic USMLE trap. The whole diagnosis boils down to one single question you have to ask yourself. Does the psychosis ever happen without the mood problems? If the answer is yes, if you can find a period of at least 2 weeks where the patient was psychotic, but their mood was totally fine, then the diagnosis is schizoaffective disorder. If the psychosis is only ever a guest during a mood episode, it's a mood disorder with psychotic features. That's it. That's the whole thing. And finally, we've got delusional disorder. For this one, I want you to picture a patient who has one or more really fixed delusions that have been there for at least a month. But here's the kicker. Outside of that specific belief, their life is pretty much normal. They go to work, they have friends, they pay their bills. Their functioning isn't trashed, which is the complete opposite of what you'd see in schizophrenia.
Okay, whew. We have covered a lot of ground. So let's bring it all together into a single super high-yield summary slide. You can use this as a quick and dirty review right before your exam.
This table is your cheat sheet. Let's just walk through the logic one more time. See how schizophrenia, schizophreniform, and brief psychotic are just lined up based on duration? Easy. Then look at schizoaffective versus mood disorder. It all comes down to that last column, that yes or no question. Can the psychosis exist on its own without a mood episode? If you can master these columns, you will crush these questions every single time.
Okay, let's apply this. We have a patient with psychosis for 3 weeks. Right away, that duration, less than a month, should make you think of brief psychotic disorder. But wait, there's also a major depressive episode happening at the exact same time. So this creates a differential, right? Is it brief psychotic disorder that just happens to have some sad mood with it, or is it major depressive disorder with psychotic features? At this exact moment, you can't be 100% sure. It's a classic wait-and-see situation. If everything goes away within the month, it was brief psychotic.
Ah, see? This new information changes everything. The fact that there's a history of psychosis without any mood symptoms is the textbook slam-dunk definition of schizoaffective disorder. It proves that the psychosis isn't just a side effect of their mood episodes, it's its own separate, co-occurring problem. And this is why, when you see a patient with psychosis, your most powerful diagnostic tool isn't an MRI, it's the timeline. So the question to leave you with is this. When you look at a patient's history, does the psychosis tell its own story? Or is it always just a chapter in the story of their mood? Answering that